you asked for a clinical scenario that highlights the issues that clinicians face when it is relating to safety. And I think every single one of us, regardless of how long we've been in practice, can identify with a safety incident that occurred to us with our patients. And one that comes to mind for me, just really encapsulates the whole issue around safety, was a medication error that I was part of. I was working in a large quaternary referral intensive care unit in the province in Canada. It was a night shift. It was a weekend. I had come to work already fatigued. It was my third night shift in a row. Um, it was Saturday night, and I remember that because the Olympics were in town, and Sidney Crosby had just scored the golden goal, and we had spent the afternoon reveling in the amazingness that was Team Canada. And I was assigned to a very sick patient, and I started off the shift with not firing on all cylinders. Obviously, I was tired, I was fatigued, I was a bit hungry. I had a whole host of distracting pieces in my life, including the fact that all of my friends were still celebrating the golden goal and I was at work. And, I was in this space that probably was already at a risk for safety or quality issue. The individual that I was taking a report from was just as excited to be gone from there as I was unexcited to be there. And so our handover was less robust than is normal, and we missed the opportunity to exchange some very important information about the patient. And I was working with a crew who was slightly less experienced than you would normally expect to see in the unit that I was working in, with a crew of supporting residents and allied health practitioners who were also less experienced than you would normally expect to experience in an ICU of that size and nature. All related, of course, to the Olympics, an external issue that had nothing to do with the patients who were in the unit and deserved our undivided attention and care. And of course, at 1 o'clock in the morning, which is always a dangerous time for the application of clinical care, and you are aware of the research that indicates that after 16 hours, it is like operating a vehicle under the influence of alcohol with a blood alcohol level, I think, of 0.5, if I recall. And then as you move past that, you get more and more intoxicated. And I say that not in the sense of being truly intoxicated, but your reaction times and your thought processes and all of the things that you need to safeguard your patient against an error are impaired the same way they would be if you had been drinking. And so I was undoubtedly impaired, and my patient's blood pressure was falling. And I was confused as to why this was happening. I didn't have a good clinical understanding of what the scenario was. And it's not an uncommon issue to see a fall in blood pressure in an intensive care unit. And yet I had this inability to be able to solve the problem that was in front of me, all these cognitive barriers, both physical, emotional, and mental. And I ended up choosing a course of action that, in the cold light of day, in retrospect, you would look back on this course of action and say to yourself, what exactly were you thinking when you decided that that was a good idea? And so what I ostensibly did was, instead of using the medication that was already at the bedside and infusing into the patient to support their blood pressure, I decided that I would go get an entirely new one and start this new medication, and that would solve the problem. And so I did that. I went to the Omnicell, which is our medication dispensing machine, and I put in the patient's name and PHN number, and I put in the medication that I wanted, and it said to me, "Are you sure you want to do this?" Big warning, this is a high risk medication. You really want to do this? And I remember thinking to myself, yes, I really want to do this. Just give me the medication. This is a time sensitive scenario. I would like to do this. And so I brought this medication back to the bedside, and I got to the point where I was about to administer it. And we also have a policy in place, another forced function that says you need to bring someone else in to double check to make sure that this is a good idea, because really we don't want you doing this entirely by yourself when you're tired and fatigued and hungry. And okay, so knock on the glass, hey, come help me out. And this is where your biases come in. This is where bias training is so important. And I had none of those things at the time. And I remember holding up the medication and saying, hey, is this medication X? Yep. This is this is what you see. Yeah, you see this. And so unfortunately, my partner was like, oh yeah, it's exactly what I see. Because I told them what they were seeing. And in fact, it had nothing to do with what I was holding. And so, now I've completed this independent double check and I'm hanging this medication, and I start the medication and I go to chart the medication, and a colleague who I've known for a very long time is literally walking by with a cup of coffee. And this is where you definitely don't want to predicate your safety systems on the individual walking by with a cup of coffee as the final check in terms of making sure that someone doesn't get irreparably harmed. And they happened to glance over at me, and they happened to look down at what I was doing, and they asked me a question, what are you doing? Oh, I've just started this medication. And she said to me, well, that's not what you're writing down. It's not the medication that you're writing down. I looked up, and I looked at her, and I looked at the medication that I was running, which was not the medication that I was thinking that I was running. And I was positive that I was giving this patient a medication that was going to solve the problem, when in fact I was giving them a medication that was going to make the problem worse. And so thankfully, I had this interaction at that moment before there was any irreparable harm, but it just aligned for me the safety conversation that we have in the practice environment every day. Some people refer to it as the Swiss cheese model. Some people refer to it as the bias model or the slow channel, fast channel thinking. There's all of these ways in which you can look at it, but I had let my fatigue, my human factors get in the way of my thinking process. And then I had slid into a fast channel thinking process, which removed the final safety barriers that should be applied in any safe system. And it was by force of luck that I was in a position to not harm the patient. There was an opportunity to create great harm. And it was providence that somebody wandered by at the right moment and had the wherewithal to actually look at what I was doing that probably saved this patient's life. And it is those near miss events in your career that forcefully propel you into the conversation around safety, and why safety and safety systems, human factors training, and the ability to spend time really engaging with what a good safety process should look like becomes so important. Because I think every clinician has experienced what I experienced, which is that near miss that could have just turned out disastrously, but didn't, but only because we got lucky. And luck is not a great way to engage in delivery of care.
Yeah, I absolutely agree. And I agree with your statement that everybody else has likely experienced some version of that over the course of their career. And if they haven't, they will. The Heinrich's triangle that you see in aviation, where you have one fatality at the top of the triangle, and underneath it, there's 10 major accidents, and underneath that, there's 30 minor, and then underneath that, there's a wedge of 600 near misses, which is, I guess, the statistical research on the likelihood of a near miss contributing to a catastrophe in aviation. And I would wager that it's something very similar in healthcare in terms of the number of near misses that happen, just getting people off on sheer luck, whether it's all the holes in the cheese line up but one at the very end, whether it's fatigue that's getting in the way or systems in the way. There's so many of those near misses that we ought to learn from that we probably have no way of capturing, or at least haven't captured. And we got to wrap up here for time, but can you close us out maybe on whether or not that event was captured in a write-up of some kind?
This is the issue. So the event was captured in the safety system that was provided at the time, and it went to an individual who reviewed it. came and talked to me about it and concluded the investigation there. And there was no further opportunity to really delve into the slices of the Swiss cheese that had lined up so perfectly that evening. There was no conversation about fatigue mitigation, for example, utilizing scheduling or utilizing staff composition or scope of practice or any of those things that could have led to interrupting that process. There was no conversation around systems safety training. There was no conversations around human factors training and being able to identify the antecedent pieces that had led to some of that decision making. So there was no safety checklist that we developed out of that conversation and said, hey, listen, if you show up to work and you're fatigued and you're hungry and you're tired, and we never implemented any of those things. And we could take learnings from the aviation industry, right? Safety checklist. This is what you need to do to be safe to come to work. You have to have so many hours of pillow time before you can, you can't have all of those things. We never spent any time taking a look at after the fact. And so I think this is our opportunity to really dig into a process that allows for not only organizations to take a look at what those pieces are, then how they lined up, but also for clinicians to feel comfortable sharing that and saying, listen, this is where I was. This is the slice of cheese. This is my slice in this process. How can I ensure that that whole doesn't line up with the other three that are on either side of it? So I'm hopeful that Dicerra is well positioned to be able to answer that question, but I am confident that I am not the first or the last clinician to have a conversation like this.
Thanks, Michael. Much appreciated.